not everyone wants to live the life
Nope.
that you want to live. Some people, when offered, shelter, they're gonna go sit in a bando kind of thing. They're gonna be like, nah, I'd rather stay at my tent. Like, I've had a patient, I knew he was living rough. He told me medically he was doing fine. And I asked him about his goals, and he was working at Walmart. He was putting money into savings. He was working to get a car.
Whoa.
He had engaged in different services, and he chose that life.
Welcome back to The Shield. This is a place where we talk about the intersection of substance use and mental health on all facets of life, and at the same time, really elevate some awesome things that are happening in Birmingham. Thank you again to our sponsors, the Children's Trust Fund, for making this possible. We could not do anything without that, so thank you. With me today are two guests, and we are going to talk about a new program Program Service Coalition. Yeah. A new initiative that is quite literally hitting the streets of Birmingham, and we're so excited. So I have Cat Cruz from One Roof, and I have Craig Borne from Cahaba Medical Care. And today we are going to talk about Care for Our Journey. Welcome, y'all.
Thank you.
Okay, so what the heck is Care for Our Journey? So, how would you describe it, Craig, in like one sentence or maybe two sentences?
Yeah, an interdisciplinary street medicine coalition.
Awesome. An interdisciplinary street medicine coalition. So, in case people still don't really know what that means, in a nutshell, other cities have had programs that are like street outreach, right? Or street medicine, street psychiatry. There's a really cool one in Montgomery happening that's street psych, where physicians and providers actually go into community. So you're reducing barriers to access and you're bringing the care to individuals. And Birmingham didn't have one of those. But we came together a lot of last year and had a ton of meetings trying to figure out like what this could look like. And I think the cool part, and we'll touch on this later, is that it's not owned by any one particular agency. There are several agencies that are all sort of bringing different skill sets to the table in an effort to create a program that is unique and unlike any other program that we've ever had here in Birmingham, certainly. But it's in a lot of ways, it's also different from what's happening across the country because of the holistic approach. So when we were starting to pull in folks, it was at the beginning, it was a lot of folks from UAB trying to figure that out. It was us at APC, Food for Our Journey, because Kelly Green, is going into community. She has 30 plus stops every day. Pulled her in, Recovery Resource Center, One Roof, and Cahaba. And there were some others, but those were the ones that kind of like kept coming back. And so, Craig, I want to start with you. Like, if what we needed to do, street psych that was happening in Montgomery was super important, and it was filling a niche. But we also knew that we wanted more holistic medical care. So can you talk about what Cahaba does sort of all the time, and then the role that you're filling with this specific project?
Yeah. So, Cahaba Medical Care. It's a set of clinics that make up like a larger health center, and so we're from really up here in the West End, all the way down through Centerville, Camden, like the reach is far down there, but a lot of the focus is like here in the West End, Fairfield, Bessemer, and then we have school-based clinics throughout as well. And so we have this like larger clinic system, and we're also a federally qualified health center.
And what does that mean for people that don't know what a FQHC is?
Yeah, and so an FQHC is a clinic that receives funding from the government, but that allows the clinic to see a majority of Medicare and Medicaid, as well as all in the insurances. But we also get to have a sliding scale, which allows people who are uninsured to receive care. And so that's, based on their income level, and it will provide basic medical care, labs, physical therapy, all the imaging and that kind of stuff that we have, which, we have x-ray, ultrasound, and then physical therapy as well at the clinic. And so with that, we have a built-in health center that can absorb people that are unhoused if needed. And then also, like, we are set up to engage in street medicine, which is a brand of medicine or a type of medicine that is bringing a full suite of clinical care to people where they are, which is super important because there's a lot of socioeconomic and structural factors and history that kind of keep our friends on the street out of, the classic clinical system.
And Cahaba in this particular, I mean, this is what you do 24/7 anyway, but in this particular initiative, you are providing like holistic care. So it could be anything from care for somebody's diabetes to if they have a wound, helping with that. It could be talk a little bit about kind of the spectrum of services that you can provide, and it's you and Sarah, right, on this project. What kinds of services are you all providing?
Yeah, and so
On the street.
Yeah, on the street. Yeah. So I'm a board certified family doctor, which just that means I practice full spectrum care, like you were saying. I can see kids, adults, elderly people, do prenatal care, obstetrics as well. And then into mental health and substance use, Suboxone and the different injectables and those kind of things. And so able to take all of that that I learned through the residency
you're
at
smart
Cahaba.
is basically.
Nah.
But Kat, is he pretty smart?
I mean, he likes to think so. He tells us a lot.
So I would imagine, though, because you can sort of treat and do you're doing the whole birth, like the whole spectrum, everything from preventative care all the way to like, holy cow, this person might even need to go into the hospital, like everything in between.
Yeah.
Whoa.
Mm-hmm. Yeah. Our residency training, which Sarah Bertrand is one of our third-year residents at Cahaba Medical.
Awesome. She's
like
awesome.
Cahaba UAB family medicine residency, which is where I graduated from. We do everything from the clinic to we train in the hospital as well. So we are hospitalists. We're obstetricians and we're ER doctors or urgent care doctors. We can kind of go everywhere, which is the beauty of family medicine and why I think a lot, like if you like other street medicine programs around the country and that kind of thing, a lot of them are either going to be family doctors or kind of med peds doctors, which is that like broad spectrum care.
Yeah, not like super specialized. Like you can kind of, the gamut.
Mm-hmm.
Wow.
Yeah.
The other like piece besides medical that was like a no-brainer as we were coming together thinking about, how we needed to structure this street medicine, street outreach, whatever you wanted to call it. The other component that was critical besides medical was housing. Mm-hmm. Like that's a no-brainer. So, Kat, can you talk in broad strokes about what does One Roof do, but then also what is the housing landscape here in Birmingham? Because I know we have some challenges.
Yeah. Well, One Roof is the hub of the continuum of care. There are hubs in various places, and what we do. My boss is going to hate me because I can't remember our.
We don't need official
However,
mission statement. Gordon, if you're listening, just smile.
What we do is we take data from folks who are experiencing homelessness in the Birmingham, St. Clair, and Shelby area to see housing resources they might be available for or they might be eligible for. And some of those may include HUD-funded housing referrals based on HUD priorities, but a lot of times not. So we try and have a good idea of what all the resources are and what all the pathways are and help folks move towards, those pathways. And that's the case management piece.
So you're
of
like
when you're
helping them
helping
navigate.
them navigate. So that's one piece. We also have a walk-in and call center. So people can kind of get those same services when they call or they walk in. Um, we are, there are some maybe not so unique challenges.
And then you have, sorry,
Birmingham.
before,
Go ahead.
you also have street outreach.
Yeah, street outreach, yes. And I am part of street outreach.
And that's where you're like boots on the ground,
Yeah.
helping people that are currently
Yeah.
experiencing homelessness
Right.
try to find
Right.
shelter, more stable housing, respite.
Kind of everything.
Okay.
So I started off as part of the regular street outreach team. There's a 4-person street outreach team that only does housing. And then this came up, and so this is more of a collaborative thing.
Mhm.
But yeah, as street outreach workers, what we do is we go out and kind of get people to a place where they're willing to engage and willing to talk about
You're building trust.
their needs. Exactly, building trust. And we're very careful about keeping that trust and keeping everything anonymous. That's a big part of what we do. As trust is built, then someone might want to share more of their information.
Mhm.
Sometimes people are in the HUD priority population, wherein we can do an assessment. We can get them into a pool of folks waiting for HUD-funded housing referrals. But as I tell clients often, there are way more people in need and eligible than there is out there. So a lot of what we do is help people navigate pathways that might already exist and just see what might already exist. So maybe it is like connecting folks to an employment service that might work for them.
Mhm.
Maybe it is helping connect folks to an agency that can help them get an ID, which will help them get to
Right.
work. There's a lot of different things. Maybe it's even interceding with friends or family member to try and help people have a place. There are a lot of different ways to get housed. Right now, I have a few clients who ended up in the ER and now are in skilled nursing care,
Mm.
and so I'm working with them to figure out if they're going to stay in skilled nursing care as permanent, using their insurance, or if they're going to be, of course, they're eligible to still be in the pool of people waiting, but are they going to be attractive to a housing project,
Mm.
who doesn't necessarily have that medical ability?
Right.
So, that's sort of what I'm doing with them now. So it's a little bit different with everyone because not everyone is in the same situation.
And Birmingham, my understanding from talking with Gordon is that Birmingham has a lot of housing, but not a lot of affordable housing.
Yeah.
Like what? Okay, what does affordable housing mean? What does that mean? Because when I moved here and I was looking for housing, it wasn't very affordable, and I have a full-time job. It wasn't very affordable.
I don't know that there probably is an official definition of affordable housing, but I think it depends on what agency you're talking to. If you're talking to HUD, that's 30% of your income, which doesn't really exist very much.
Right.
If you're talking to developers, it's less than they would charge normally, but really not affordable. What we have is a lot of housing that doesn't match the economy of the neighborhoods. Even here in Titusville, the average income and the average housing prices don't match.
Right.
Which is what spurs gentrification, of course, and makes it even harder.
And something even more challenging that just sort of compounds on all of this, and again, this wasn't just in Birmingham, this was like nationwide, was the closing of several mental health institutions and things like that forced a lot of people onto the streets.
Mm-hmm.
And so the Care for Our Journey initiative really sort of targets, aims, attempts to provide services for those people that are unhoused, correct? And we're bringing the services to them.
Yes. One thing that made me feel really passionate about this project is, yes, on the ground, there are 3 different agencies. There's Recovery Resource, Cahaba, and One Roof.
Yeah, that are doing the work every day.
Yes, and we do 3 separate things, but it's a collaborative initiative because in HUD best practices are housing first. That means housing before anything else. But that does not mean that housing is the most important thing. Everything is the most important thing. We can think of medical care as a housing need, or as housing as a medical need,
Or
and
food.
recovery.
Right.
So if we think of acting together as a coalition, as opposed to different services in a silo, given the fact that, beggars can't be choosers and we don't have enough services, it makes the most sense to act together and think of ourselves as a team as opposed to 3 separate services.
Absolutely.
And that's what interests me about this so much, is the collaboration. And it makes it more difficult, We're all doing different things.
Yeah.
We're all different people.
We're all different agencies. We have different boards. We all need different data sets and all the things. But
when it comes down to it, we can get more done for the client and move them further, quicker, client, patient, whoever.
Yeah.
If we work this way. If someone is not ready to engage with me about housing, they may engage with Chris Albright, who is our recovery resource peer, about recovery.
Yep.
They may engage with Craig about medical. If they engage with Craig and they also need to talk about housing, he doesn't have to say, here's the phone number, call this person.
Right.
He can call me over.
Right.
And that, I think, really opens a lot of doors for us in terms of trust with folks living on these streets.
Because that was something that was paramount when we were all in the room talking, and this was something that Kelly Green was like so set on, is it's all calling them friends, building community, protecting trust. We were very slow with the quote unquote rollout because we wanted to be very intentional. We wanted to keep showing up. We sort of piggybacked off of Food for Our Journey at first because they are people who have the trust in community and go out kind of day after day. And so in terms of the mechanics of the program, Kat, you mentioned a little bit about it. So RRC, Recovery Resource Center, One Roof, and Cahaba, you 3 are the boots on the ground. So there's always a peer. There's always a person from One Roof to help with housing and navigation for shelter or whatever. And there's always a medical person. So, most of the time.
Most of the time.
And so can you talk, I don't need like specific stops or anything like that, but can you talk about, and there's a reason for that.
Oh yeah.
Yeah.
Right?
Yeah.
So some people might be saying, well, why can't I go and, help out? Well, it doesn't work like that because
privacy.
Privacy, exactly.
We're going to people's homes.
It's also why there aren't any of our friends or clients on this podcast. Like, we want to be careful, and we're going into people's homes. We're meeting them where they are, and just because their home doesn't look like our home doesn't mean that, we all just get to show up. It's still their home.
Yeah.
Right. So we're not talking specific stops, but in general, could you walk me through maybe like a typical day? Doesn't have to be a particular stop, although I will just say that, correct me if I'm wrong, but a lot of the work that's happening is happening on the outskirts of downtown, correct?
I feel like it's a good mix.
A good mix.
Yeah.
Okay.
We've been taking data since October.
Yeah.
And we've built out a route. We kind of started following Food for Our Journey, but because of the different services we provide, it doesn't work perfectly.
it doesn't work
and
perfectly.
and because of the time, we just
And
it's just
timing.
timing.
Yeah.
So
They're going pretty quick.
Yeah.
Yeah,
I mean,
and they
Whereas
have
you
to.
might
got a
have
lot.
somebody
She's got a
in
lot.
there with you for an hour.
Yeah, I mean, a good clinic morning, like in the clinic, in the like actual clinical setting where people are coming to me with appointments and that kind of stuff, I can see 12 to 15, on a good clinic morning. Kelly serves up to, I mean, averagely, I think talking to her, she serves anywhere between like 180 to like 250 meals
I mean, right.
a day.
Right.
And so
So that's
the
like where
numbers
we
just don't match.
started, but then
Yeah.
we had to adapt, which is part of
And they're just effort services, and the beauty of it is all these services work well
Totally.
together. But we need to respect that we need to do things differently
Totally.
in terms of time and management and all of those things.
so like
But-
what's a day? What's a day look like? A typical Care for Our Journey day.
We get on the van at 9:00, and we go out to our first stops.
Typically there's 2 stops a day?
Three,
3.
4.
Okay.
Like 8.
It depends.
It
really.
depends. Okay.
Um,
All right. So 9 a.m. You get on the van. What van?
So
Like
the
paint
one roof
a
van.
picture. Okay, the
So,
one roof van.
Yeah, we have a van at One Roof that no one wants to drive but me, so we get to drive it. It's our mystery vehicle.
Pulled the short straw on that one. Okay.
I
so we
mean,
get
I
on
love the soccer van.
Okay.
It's great. It's got the room for us. We go to our first stop, and we just go to stops all day and see people.
and you're
some-
just chatting with people at this point.
It depends. We're doing what's needed. We at this point, folks know us. They know where we're going. We pull up.
So you have like an established route,
Yes,
right? So they
yes.
know where you're going to be.
And it does change. If we go to a place like 2 or 3 times and there's no one, we generally move on to something else. When we do that, I'm able to talk to the regular outreach team to make sure that they're continuing to check.
Got it. Okay.
To make, because people move around a lot.
Yeah. People
Yeah.
move.
People move around.
Yeah. And they have
Because
to,
a lot of times they get kicked out of where
they
they
have
are.
to move around. Yeah.
They have to move. Right.
Right.
The city, the city does. The city has like their job and their initiatives as well, and sometimes that runs kind of in friction with our friends on the street, and so we just continue to travel with them.
Yep.
As they go.
All right. So 9 a.m. you pull up in the soccer mom van. Okay. And
We get out, say we're at a park, right?
Okay.
We get out, One Roof, Cahaba, Recovery Resource. We kind of yell out, say who we are. Sometimes people are there already. And we just offer services, have conversations, see what people might be interested in. Sometimes people don't want anything. We get back in the van and go. Sometimes we have people we know that we're seeing because that has been set up beforehand by one of us, by Food for Our Journey. And, so at that point, we just kind of offer whatever. Sometimes it's me sitting down and having a conversation about housing and doing an intake and assessment. Sometimes it's Craig sitting down and figuring out what the medical needs are. Sometimes it's Chris sitting down and talking with them about addiction and where they are and what they might want to do around that. Honestly, I think that's probably the hardest piece of it. Because it's, people do these things to deal with a horrible life.
to cope. Right.
And I think it's a really hard thing to sell. Like, hey, stop doing that thing that's keeping you alive.
Yeah. And, it was critical for us to have not just somebody from Recovery Resource Center, but also obviously APC wanted to be involved. We help with wound care kits, and our community collaborative board sort of provides like a little bit of oversight, for lack of a better word, but I don't even know if that's the right word. Accountability. But then also, like, it was important for us to provide some medication for opioid use disorder, because some of the funding is coming from opioid settlement grants, from the Birmingham City opioid settlement, as well as Jefferson County as well. Yep. And so can you talk a little bit about that kind of intersection? Like, let's say that, there is somebody that has been identified as struggling and they want some help. how do you get involved at that point then?
Yeah. And so, yeah, I think, yeah, like what Kat said, like we do go out. And so, yeah, we're all in the van. We kind of go out.
And
so
it's like
it
team,
is,
like it's like
yeah,
like
we're all
okay, cool.
hauling out
Yeah.
of the van, you know.
And you're not wearing your white coat,
No, for
right?
sure.
Okay,
Yeah,
good.
I barely
okay.
wear my white coat in the clinic.
And that's
nowadays anyway.
intentional,
Yeah,
right?
It is intentional,
Okay,
of course. And so, yeah, and so it's, I mean, yeah, it's going to our friends with love, right? And like that's the kind of the point.
That's the point.
And so, yeah, but we are going to their home, and so the key difference between clinical medicine and street medicine is that we are going to their home, and oftentimes it's uninvited kind of thing. And so there's a ethos there. There's a empathy there. There's a difference in engagement. And so you have to just reach out and be like, hey, do you want to talk today? Do you not want to talk today? It's totally okay.
Yeah, where are we at today?
But then also there's you have to discuss what you can bring to the table well. And so you have to reach out and be like, hey, I'm a doctor, right? And so if you want to talk about any medical needs, I'd be happy to. If you have any questions, like if you want to engage in any like substance use discussions, anything like that, if you need medicine that you are supposed to have had, hey, when's the last time you went to the ER? Do you have any questions since you were last at the ER? Because like everyone usually does, right? And so yeah, and then like, hey, I'm with One Roof, and One Roof is, you know, institution in Birmingham, right? And so they know.
Yeah.
The van also has like housing on
Yes,
it, and so
right.
a lot of our friends know kind of what's going on there, and then recovery resources as well. And so yeah, and so when something's identified, like a medical need, a medicine need, or an addictions need, you just discuss the different options, just like you would in a clinical setting.
Yep.
You say, hey, and a lot of them know, you know, it's most often of the time, it's not their first like rodeo kind of thing.
Yep.
And so, yeah, I'll talk about, you know, hey, I know these few methadone clinics around, but I can also write you Suboxone. I can write you a long-acting injectable, Sublocade, and we can get going on this. I can bring it to you.
I don't think people understand just how amazing this is. I mean, really, it's just, it's really incredible.
It is.
It's incredible.
It is.
It really is. I mean, a lot of times we come out of the van, we introduce ourselves as starting with One Roof because we have been out here for 30 years.
Oh,
People
for sure.
know who One Roof is, and then we sort of build on that. But, I mean, within the first couple of weeks, I think Craig came out with a joint shot to give to someone, and I was just, like, flabbergasted because these are the kind of barriers that we've run up to with our clients that we can like slowly chip away at.
Yeah.
But the more that happens, the more that the person is giving up. You know?
Right.
So the fact that we can just do that.
Well, and people have such inherent, I mean, I was a teacher and I know people have a lot of feelings about education systems and a lot of mistrust, especially if they had like particular experiences. And it's the same with medical care, right? People fear doctors, or they think that they, you know, that physicians tell them what to do, that they don't get to ask any questions, and they might have had a traumatic experience with a doctor and
Just a lifetime of experience.
exactly. And the fact that you're there, that you might be able to help with a joint shot or some, you know, whatever it is, like whatever it is. I mean, that's pretty incredible. Why are you doing this? Like, what? I mean, I wanted to get through the like logistics, but like, here's what I really am curious about. Why are you doing this? You could probably go anywhere and make a gajillion dollars, and you wouldn't be like on the street in probably some pretty gnarly conditions, if we're being honest. What are you doing?
Yeah. I mean, my journey, includes, undergrad and then.
Did you always know you wanted to be a doctor?
I grew up, there was, from kind of a young age, I kind of knew. And then, And then it really solidified like through my different experiences of like working in Alaska and then like living in Bolivia and different things like that I did.
So cool.
And so
We're like a hipster Patch Adams.
and so yeah, and then but I think my first like true exposure probably was in medical school when I did like a month fellowship up in Pittsburgh, where I got to meet, like I got to meet Jim Withers and
These are like pioneers of street medicine, street outreach. Yeah.
And I was introduced to addictions medicine and street medicine at that point and kind of different ways to do medicine and to provide medicine to people. And just kind of always, I believe everyone should be able to receive healthcare. And I believe everyone should be able to receive love. And I believe everyone should be able to be treated equally, and be uplifted. And so what that looks like doesn't look like a normal, private clinic setting.
Yeah.
I like working in the hospital, and that is also where people can receive care, but that's sick care, not health care. And so I desire to, so being able to serve any and everybody that walks into the clinic or that I talk to on the street, and being able to promote their health, because
like wellness, like full-bodied wellness.
Because if you
Mental,
can get there,
physical.
Yep. If you can get there physically, if I can help you reach another step in your physical health and another step in your mental health, then we can start working on your spiritual health, and then the whole, I'm going to mess it up, but like the pillars of
8 dimensions of wellness,
something like that.
Something like that.
We
know what you're saying.
Having
we got it.
Like health,
yeah.
shelter, food, like your basic needs kind of thing. And that's the beauty of interdisciplinary street medicine is we're working on sheltering, right? We're working on, Kelly and Food for a Journey is providing the food, the sustenance, and then there's the physical health aspect of that. And that's when you can start, achieving your goals. And I think everyone should be able to work towards achieving their goals or like doing the things they want to do.
Yeah, it's like that Maslow's hierarchy, right? Like you can't even like think about what it means to feel satisfied or fulfilled or like thriving if you're not surviving.
Yeah, if you're hurting, sick, if you don't know where your next meal is coming from or you don't know where you're sleeping. And that's like really one of the most tragic things about our friends is that they just don't even know where they can put their bodies on any given night sometimes. And so that's where the beauty of this comes from. And so that's like where the absolute truly evidence-based
Yes.
Version of this coalition comes from is because we are including medicine. We're including housing first, right? We're including like addictions support, and food. And in this, like housing first initiatives, yes, are important, and they're like the normal they're kind of the current political, like that's the stance, and it is important, and shelter is important, but housing first initiatives with medicine, and with continued outreach are significantly more successful, than housing first outreach alone.
Totally.
I mean, housing first does mean housing with wraparound service.
But the
it's
reason Kat and I paused, and I will say it so you don't have to say it, but housing first as a model has come under attack, just like harm reduction. And these are words that we're not really supposed to say anymore, and we're supposed to move away from research and from what we know is working. And that really sucks. I'm just going to be really blatant and say it really sucks. And what you're describing is a comprehensive model that includes housing, because people have to know where to put their bodies at night before they can think about, how do you even get a job if you don't have an ID? And you don't. Exactly. You don't. Kat, you're intense about housing. Okay. You are like intense. You are like a bulldog when it comes to this. You are quiet. And when you speak, you have very strong opinions. And I mean that as a compliment, right? Would
It's
you?
true. No,
Okay.
her opinions are great.
So where does your, and this episode might go a little longer because I'm just like this, it's just amazing to me. This project is just amazing. So why are you in housing? Because like this field is not for the faint of heart.
It's not.
And where does your intensity come from?
I was a teacher as well.
Oh no way. I didn't know
Yeah,
that.
I taught in Oakland, California. It was an alternative charter school for youth, so up to
I
26.
can totally see this. Okay.
It was amazing. A lot of my students were dealing with housing insecurity.
Yep.
Some of them homeless, some of them doubled up, tripled up. Some people went into the shelter so they could stay in school.
Right.
We had a licensed therapist there. She dealt with a lot of this, and it was always really interesting to me, and I wanted to know more, but I just didn't have the time. You've taught, you know what it's like.
Right.
But when I moved here, I started immediately volunteering in homeless services, and it just caught me up. I didn't want to teach anymore. I can't imagine, honestly, doing something where I don't learn from the people I'm working with. I mean, that's what happened when I was teaching. That's what happened now. It feels like a huge privilege to be around people and hear parts of their stories and be trusted with that. To kind of take a moment out of the day where you're really having a real conversation, you're making eye contact, you're
Which might be the first time
feeling
somebody's here
Yeah.
getting that.
right. And I think the services we offer are great and very important. But what we offer that can't really be quantified is community and care. People look away from our folks.
Right.
And I think I've mostly spent my career working with people who people look away from, whether it's children or people disenfranchised in some way. And that is it. Those are the people who are interesting. You know, those are the people who have stories and have something to offer, and those are the communities I want to be part of. And I guess that's why I'm doing this.
I would ask both of you about like compassion fatigue or burnout,
Mm.
but I don't really get that from you two. And you both seem to like, I don't want to say live in community, but like, I feel like the choices you make beyond the confines of your normal work day, like what is a normal work day? Like it kind of all
Mhm.
blends sort of. Do you know what I'm saying? Like,
Yeah.
Everyone has their own way to deal with compassion fatigue.
yeah.
That's going to be a definite part of anyone who does anything like this. Bringing your work home and secondary trauma and compassion fatigue. Everyone has their ways to deal with it. We just have to get to the point where we give ourselves permission to do that. And that might sometimes takes a while. Sometimes people know that right off. For me, it took a while, you know, but I'm there now.
Yeah. Okay. All right.
Yeah. I think like around some of that and like burnout and those kind of things. I think there's a few things, and you know one of the first things I kind of go to is I think we are all uniquely created and have such a unique journey to do the things that we are doing.
Yeah. Yeah. Yeah.
And so like
Yeah.
honestly, if you put me in a hospital, I would need,
You would crash out.
I would need a year vacation. If you put me in a private care clinic, you know, and in like a rural setting, I would probably crash out, you know, that's just not where my heart and passion is. And so when you are working where your heart and where your passion is and like where your training has been, you like,
It's like
reaching that burnout level
Yeah.
is a lot it's a lot further away. And then I've actually was talking with one of the case managers at Firehouse where I was doing some work the other week, and she was like, yeah, my optimism is just kind of like running out. And I was like, everybody's does, and you have some weeks where your optimism is like super high, and your hope and your grace and all that kind of stuff. And when that happens, great, push into it, lean into it, run it, right? Just full send. But then when it runs out and it starts to wane, what you do is you lean on your boundaries, and you lean on your training, and you lean on what you know you can provide. And if you were giving everything you can up to your training, up to your boundaries, then you're giving them all they got.
Yeah.
Right? And that's okay. Because that's when you have a team, right?
Right.
And so that's when you have
That's
other
right.
services, and that's when you know how to link into other things.
Yeah. You need
And
a
that's
team for sure.
and it takes a village, right?
Okay.
We're built for community.
We are built for community. So
Say one more
yeah,
thing.
go for
I
it.
feel like a big part of it is making sure that we're not infantilizing the people that we work with. They don't,
See,
they don't need us to
Get it.
do everything. And
Right.
if we're doing everything, we're enabling. We're doing a disservice. I think part of it is like trusting people to survive because they have survived.
Yeah,
before
autonomy.
us,
They
and
still
they
have
will
autonomy.
survive after
Mhm.
us.
Right.
We're not gods. We're just people just like them,
Mhm.
and we're on this journey together. We're not necessarily leading.
And that's
so I
why
think-
that's why we intentionally named it Care for Our Journey. Like it is a journey. We're
Right.
not, it's not cure for our journey. Like we're not curing anything.
And I think that mentality very much helps me because it's
Mm.
not like thinking, oh my God, this is my little child. If I don't do this or this, they're gonna die, because it's not. They're not. They're full grown people
Yeah.
with,
It prevents you from like having like a savior complex.
Right.
Yes.
Right. And I think that's one of the worst things that can happen here. You can do way more harm.
And
than
what
you're
we've
doing
done
good.
for a long time
Yeah,
we're going to swoop in, we're going to fix it. We're
And
gonna,
that's exhausting.
especially honestly, sorry, but us as white people, like
Mhm.
as a
Yeah.
culture, like us being like, oh, we will fix it. And like that.
Yep.
No, you're exactly right. And that is our culture. So it's something that we as white people have to be thinking about
Right.
all the time so that we don't fall into that, because it's easy. It's
Totally,
easy.
totally.
That's what's been built for us.
Mm-hmm.
Yeah, I often think through that as like, so like in medical school recently, there's been a change, but like that's called like paternalistic medicine, right?
Oh.
Is like, that's the
okay.
kind of, verbiage around that is like, I'm the doctor. This is what's best for you. I tell you to do it and you do it.
Yeah, people don't know that
And
you
so-
can actually ask questions of your doctor. Like when
Yeah.
we go out and we do trainings around Narcan and opioids and things like that, when I'll say to full-grown adults, like, hey, if you don't like the medicine that's being prescribed to you, if you're not liking how it's making you feel, just because you're given an opioid prescription or fill in the blank with another prescription, you get to ask questions. And like the looks on people's faces is like,
Oh, yeah.
really?
Yeah. I would say, please trust your doctor and always
of
get a second
course,
opinion.
of course.
For sure. But no, I also am very pro like when starting different medicines and those kind of things. Specifically for like different conditions. It's like, yeah, let's try it.
Yeah, let's
See how you do. And I mean, medicine's great now. There's a ton of options. And so like if you don't like the blood pressure medicine you're on, there's another version of it, right?
Right.
That kind of thing. And so yeah. And then also just
Holistic
like
medicine.
and then also there's just like the like, yes, you like mentioned like we as white people, like also we as privileged, but also just kind of we as, and I'm saying we because that's where I came from, is like suburban America.
Yeah,
Go experience a different culture, right?
totally.
Not everyone wants to live the life
Nope.
that you want to live. And so
That's right.
some people, they like to be rough sleepers. Some people, when offered, shelter, they're gonna like go sit in a bando kind of thing. They're gonna be like, nah, I'd rather stay in my tent.
Mhm.
Like I'd rather stay out in the woods kind of thing. Like I've had a patient in my clinic actually for a while who I knew he was unhoused. unhoused. I knew he was living rough. He told me, and like medically, he was doing fine. And I asked him about his goals, and he was working at Walmart. He was putting money into savings. He was working to get a car.
Whoa.
He had engaged in different services, and he chose that life. And I was like, and so I would, run the safety screenings, all that kind of stuff. I would always check up on him. I would, do the bit of extra screenings because he was living rough and that kind of stuff. And we had a great relationship, and now he's got his own apartment,
And he was ready when he was ready.
He's ready when he was ready.
And that's got to be okay for us to accept. Yeah. That's a widening of our horizons, and that's a benefit of the job to me.
Yeah.
I mean, I have a guy I met who he lived in a tent for 3 years, saved his money, bought a house, doesn't owe anything. You know? There are different ways to live life.
Yeah. Yeah, and that has to be okay.
And I think that's important. For me, it keeps me from being complacent.
Mm-hmm.
I get a lot from this work. It's not just giving; it's receiving.
Can you tell me, no names, of course, but can you tell me about a success story? You've been doing this work since October. Mm-hmm. Can you talk about a client, a friend, who received sort of some medical care, some, whatever that looks like, and no names, but kind of tell me, like, I don't know if you want to share this one, but the one that you said at the last meeting where it was like, this is why we do what we do. It's like the person who eventually went in for anyway. You say whatever you want to say, but talk to me about a success story. This is how we're going to end this, because we're so damn proud of this, and it's just so cool.
I think Kat's got the housing success stories.
Well, I think success looks different.
Yeah. Yes, that's right. Exactly. That's what I was hoping. Yes,
there are
exactly.
Success stories that end in this person is now housed and getting medical care and on the road to get a job or whatever.
That's one version of success.
There are success stories of this person is getting fairly regular medical care,
which
now.
Is a success.
It's a huge success. There are success stories, that are like, this person has been engaging with us for a couple months and has finally decided to try treatment.
Yep.
So it really, you have to expand your idea of success. So
Love
it's not
it.
Just one thing.
Because
everyone starts in a different place. Everyone has different goals, and those goals change all the time.
Yep.
A success story might just be a person has managed to sit down and focus their mind on their goals, or they've gotten an ID, or they've gotten a warrant out of the way.
Mm-hmm.
And all of the things I'm saying, I have a person in mind for them, all. But it's all different.
One
person's success and another person's success are different.
Awesome.
Yeah.
Anything to add?
Yeah. No. Yeah. I have all those people that you were saying. I think like a couple other ones, like one guy thought he was walking around with a cancer on his arm. Did a biopsy. It wasn't cancer. Oh, yeah. Got to
that was amazing.
Tell him no. Hey, you're good, man.
That's happened a few times now.
Oh my gosh. Can you imagine
the
relief?
Yeah. Oh. And so yeah, and then like that kind of thing, and then also just like different things like for the times when people do have to go to the hospital. Like it is a true medical emergency.
Which that is a success in and of itself to actually get people to go, right?
Yeah. And so I think that was kind of like the thing is like, sometimes it is a true medical emergency and they are just terribly resistant because everything they own is right there on the street. And if they go to the hospital,
then what happens to
their stuff?
Right.
And so, I can think of a couple of people that we worked with where it's like, I'll go out and I'll be like, okay. And like, I'd be like, hey, I really think we should do this, but there's a couple of things I can try. And so we try it with them just because, like, again, they have agency.
Yep.
And so I'll try it with them, and then I'll come back and follow up and be like, hey, you see it's not getting better. And sadly, let's work through a process. And so in that time, we as a team are contingency planning on how to help them get into the care they need, but also protect the things that they are concerned about, and then help them, and then continue to engage with the medical system and help them discharge well.
Yep.
And that's so important because, if you call an ambulance, they have a very specific job, and their job has nothing to do with making sure you keep your stuff.
Totally. Or
So a
your
lot of-
dog or
A
your
lot of times
whatever,
people,
right?
They fall out and they end up in the hospital, and that ID that took them forever
Ugh,
to get,
right.
they don't have anymore.
Right.
And, that's understandable. If you are working on an ambulance, your job is to keep that person
Absolutely.
alive. And they have to be able to do just that. But what we can do, because we're collaborative, is make sure that, we can limit all the different kinds of harm that can come to someone in this situation.
I really think this is like one of the coolest things to happen to the city in a really long time. And I'm so grateful for you two, grateful for all of the other team members that are making this happen, that weren't here today. You all drew the short straws and you were elected to be here. But it's just been really beautiful to see everybody kind of push their egos aside and do the work. And so thank you both for being here.
Thanks for having us.
It's just incredible. Ronnie, I just love this project. If you like what you heard, please consider rating, reviewing, and subscribing to The Shield. And also, if you're interested in supporting this initiative, the Care for Our Journey initiative is housed on the One Roof's page. There's an Amazon wish list if you want to help support with like sleeping bags, socks, wound care supplies, things like that. Or if you want to figure out how to support it in your own way. That does not look like coming into community and walking with Kat and Craig. It's not what that looks like. But if you would like to support in other ways, please go to One Roof's website and look at the Care for Our Journey page and figure out how you can tap in. Thank you very much.
Thank you.
Thank you.